Hello, my name is Janiel Rodriguez Dorado. I am a second year resident at JFK Medical Center and I will be presenting a case report, Staphylococcal toxic shock syndrome. Every minute counts. Toxic shock syndrome is a severe life-threatening condition with high mortality and incident rates. It has been classically associated with tampon use in menstruating women. However, non-menstrual cases are also important to consider. We report a case of staphylococcal toxic shock syndrome in an immunocompetent male patient. This is a 36-year-old male with no past medical history who presented to the emergency room with 3 days history of fever, polyuria, polydipsia, bilateral lower extremity weakness, decreased appetite, and weight loss. On presentation, the patient had a temperature of 39 degrees Celsius, a blood pressure of 94/54, and a heart rate of 114 beats per minute. His blood work was significant for a white blood count of 2, bandemia of 19.5%, and a bicarb less than 7. His blood sugar was 692 milligrams per deciliter. Further workup showed a lactic acid of 7.2, a creatinine phosphokinase in the 7,000s, and a CRP greater than 45. His arterial blood gas was significant for a pH of 7.11, a partial pressure of carbon dioxide of 16.5. The patient was admitted to the ICU and started on vasopressors as well as empiric antibiotics with vancomycin, cefepime, and clindamycin. Blood cultures were positive for methicillin-susceptible Staphylococcus aureus, also known as MSSA, and an echocardiogram was negative for vegetations. The patient sustained a cardiopulmonary arrest on hospital day 3, but return to spontaneous circulation was achieved after 4 minutes, at which point the patient was intubated. The patient subsequently developed a diffuse macular rash on the torso and upper extremities, which progressed to desquamation and spread to the lower extremities in the following days. Unfortunately, the patient died after another cardiac arrest on hospital day number 10. Staphylococcus aureus and Streptococcus pyogenes are the most common microorganisms associated with the pathogenesis of toxic shock syndrome due to the ability to produce a toxin also called toxic shock syndrome toxin 1. In addition, exotoxins, also known as superantigens, can activate a vast amount of T cells, causing a massive cytokine production. The clinical manifestation of this disease includes fever, hypotension, a diffuse macular rash, and multi-organ failure, followed by skin desquamation in 1 to 2 weeks. Proper management should involve IV fluids, vasopressors, and antibiotic therapy, including vancomycin and clindamycin, in addition to other broad-spectrum antibiotics like cefepime or piperacillin tazobactam. Clindamycin is particularly useful for its ability to suppress the synthesis of bacterial toxins. The length of treatment varies from 10 to 14 days. However, the therapy should be continued until the patient remains hemodynamically stable for 48 to 72 hours. The case fatality rate is significantly higher with streptococcal toxic shock syndrome, which exceeds 50%, in comparison with non-streptococcal toxic shock syndrome, which is less than 3%. Although the mortality rate in menstrual cases have decreased significantly, the mortality associated to non-menstrual staphylococcal toxic shock syndrome remains unchanged at 6%. Since early detection and proper management are crucial to survival, physicians should consider toxic shock syndrome in the differential diagnosis of shock in adult male patients. Thank you so much.